Good afternoon, good morning, good evening, everyone joining us from all around the world. My name is Nuhu Yakub. I'm with the Department for Maternal, Newborn, Child and Adolescent Health in WHO headquarters. And welcoming everyone for this webinar, where we'll be looking at country learnings and opportunities to advancing pediatric quality of care. Before we start, we'll just make a few announcements on the management of the meeting. This meeting is going to be in both French and English. There's going to be simultaneous translation. Cette réunion en français est en anglais. Pour écouter l'audio en français, cliquez sur l'interprétation et sélectionnez français. So you can go and move between English and French. And therefore, we will please introduce yourself in the chat box and remain on mute if you're not speaking. Also, we'll be recording the presentations and sharing it and the recordings with all participants via email after the meeting. So, welcome everybody. Next slide, please. So this is a webinar that is jointly being hosted by the Child Health Task Force, specifically the Pediatric Quality of Care Pediatric Sub-Working Group, which is really trying to create a platform in child health community to advocate for and provide for support to improve quality of care for children. It's also hosted, as most of you know, with the Quality of Care Network, the Network for Improving Quality of Care for Maternal, Newborn, and Child Health, has been implemented in 10 countries and starting since 2017. Next slide, please. So for this webinar, it's actually going to be it's going to be the first of a series of webinars. And at the end of this session today, my colleague Andechin from Ministries of Health will discuss these other upcoming webinars. But for today, we're going to basically be sharing countries' efforts and experiences on designing and implementing national and subnational programs for improving quality of care for children from 2 countries, from Kenya and Uganda. I will be talking about and discussing with you participants to be an interactive forum and discussion around what are the emerging opportunities, what should be the priorities for moving forward to improving quality of care for children. And we'll be linking that with the recent meeting that happened in Ghana in March of this year, which was the end of the first phase of the network. Next slide, please. So in terms of the agenda, as I already introduced myself, my name is Nuhu Yakub with WHO Geneva. We'll have 2 colleagues really who were very grateful that have made time to join us today from their busy schedule. We have Dr. Janet Karimi, who is the head of Newborn and Child Health Division in the Ministry of Health in Kenya. She will be discussing about what's basically how Kenya is going about implementing pediatric quality of care, where is the focus, and maybe some of the issues and challenges. And then we'll also have Dr. Jessica Sabiti, who is the Commissioner for Maternal, Newborn, and Child Health, Ministry of Health, Uganda, and she will be taking sort of a broader view, looking at how you integrate this child health also with maternal, newborn health quality of care. What are some of the entry points that when you're thinking about child health, pediatric quality of care, you can be thinking about, and also what are some of the opportunities as well. So she will be sharing experiences from Uganda. And then the last speaker will be Dr. Ann Detstrin, my colleague from UNICEF New York. And she will be discussing introducing what were the outcomes from the discussions in the meeting, the Quality of Care Network meeting in Ghana in March. But how does that link with what's the work that is going forward around opportunities, barriers for countries to begin to work around pediatric quality of care? So as I said, it's going to be an interactive session. There will be discussions. You have the opportunity to ask questions. We will share those questions with the panel, and we will have sort of discussion. And we hope at the end of today, we'll have some clear ideas and some about how do we go about this? How do we link with ongoing work with maternal and newborn health? And what are those areas, specific issues that we should be thinking about for child health? And then, as I said, finally, Dr. Andech will come in and just talk about how we envision the upcoming webinar series around pediatric quality of care. We feel there's an opportunity now, so we really want to build on the momentum that's happening, what's happening in many countries right now. Next slide, please. So why why are we trying to reinvigorate and re-emphasize priorities around pediatric quality of care? We know that particularly since 2000, many countries have made substantial progress in reducing preventable under 5 mortality. And a lot of countries are on track to meeting the 2030 SDG targets. But we do know that there are still countries where this progress has lagged. Unfortunately, most of those countries are situated in sub-Saharan Africa and also in Asia. So it's very now, we now know the regions where this is happening. And we also know that for many of these countries, coverage is not enough. So it's not just going to be enough to increase coverage of essential child health interventions. We need to be thinking about, particularly at the primary care level, how do you improve the quality of care when children are seen by healthcare workers? And how do we ensure that the experience of care are positive so that mothers and caregivers and fathers continue to access healthcare? So for us, we want to say, how do we begin to think about programming for child health quality of care? Next slide, please. So we also know that quality is not a given. Countries will have to actually, and that's the focus of this first webinar, countries will actually need to think about strategically, how do you envision quality of care across the continuum, so including maternal newborn, but also now child health. How do you plan? What investments are necessary? And after implementation, what monitoring indicators will be needed to begin to continue to track progress? So the network for improving quality of care served as that platform, particularly for maternal newborn health in the 10 network countries, but actually crucially, the lessons have been translated to other countries since 2017. And the idea is the network has basically served as a pathfinder in bringing together health systems strengthened for quality of care with maternal and child health programs. And at the end of in the meeting in March, I think there was a recognition of the huge successes that have been made, but also a realization of the unfinished agenda, both within maternal newborn health, but crucially also within pediatric quality of care. How do we begin to bring pediatric care into this discussion and platforms already existing at country level? And also moving forward, how can the network be a mechanism for implementing the unfinished agenda for maternal newborn child health? So whether it's ending preventable maternal mortality, the Every Newborn Action Plan, or the Child Survival Action Plan. So how can the network and also how can be the platform to make sure that all of these initiatives that are being implemented in countries in driving the agenda towards 2030 is being utilized sufficiently? And also, how can the network, building on the progress and successes we saw in maternal and newborn health, also be together working with other platforms like the Child Health Task Force, be a learning platform to drive peer-to-peer learning, to share what's happening across countries, and also to show and see what are the implementation barriers and challenges that are still being suffered in countries. Next slide, please. And for child health specifically, we do know that crucially, as countries begin to make investment to strengthen primary health care, it is crucially and important, particularly for childhood, because we do know that for most children, in childhood, most children that are sick will be seen at the primary health care level. So how do you ensure that, starting at the community to the first level referral facility and also at the hospital, we ensure that across this continuum of care, there is high level quality care that's provided, and also during referral. And we know, next slide, please. And to do that, I mean, WHO in 2018 and initially in 2018 developed the pediatric quality of care framework and standards, which looked at how quality of care can be improved at facility level. And that was followed in 2020 with the standards for the small and sick newborn care. And both of the standards basically situated quality of care, like similar to maternal and newborn health, around the provision of care and also experience of care. And we're informed by the health system building blocks applicable to all health facilities. So even at the lowest level health facilities to the highest level health facilities. And it's centered around newborn, at the center of care is newborn, child, and adolescent health. crucially, one area of gap that's been, and I think Anne will discuss this also, is we do not yet have standards for community, we do not have community standards yet, but so how, as countries begin to think about, countries thinking about pediatric quality of care, will this be implemented, starting crucially also at community level? Next slide, please. In addition to the standards, we also now have the pediatric quality of care indicators, which is a core group and 25 indicators, which countries can look at and select based on their implementation priorities, based on their program priorities for child health. So include and integrate into their health information systems. And in addition to, particularly at the national level, but also at subnational level. And these indicators have been looked at and are currently, work is ongoing in a few countries to see that what is the feasibility about collection and use, and also perhaps in this indicator, what are the similarities with other indicators that are currently defined at country level? Next slide, please. And finally, my final slide, looking at, we do know already there are a number of tools that have been developed for child health quality of care. So we are not starting at zero. We have the ICCM chat booklet starting at the community level, the IMCI chat booklet, which outlines how care should be provided at primary healthcare level, and also the pediatric pocket book, which looks at the pediatric emergency trial and assessment and treatment guides, which provide the care for how quality of care that should be provided at first level referral and hospital level. Both of these documents are in the process of being updated. So we hope that by next year we'll have both of these documents updated, which will also include some new areas like sickle cell disease, asthma, pediatric asthma, and also care for this child with diabetes in the hospital level. In addition, we have the pediatric vet audit tools and also the point of care quality improvement tools, which together there is an opportunity for countries already to begin to use this guide and documents in terms of thinking about programming, what are the tools needed and how can they be adapted. So today we will be listening to how some of these tools have been used and also what's unique entry points and unique operational issues that have been faced in Kenya and Uganda. Next slide, please. So as I said, we will have two main discussants. We have Dr. Janet Karimi, who will be discussing on experiences with implementing in Kenya, and that will be followed by Dr. Jessica Sabiti, who will be talking about the experiences in Uganda. And after that, we will have a panel discussion. So I think now I'll be handing over to Dr. Janet Karimi to make her presentation. Next one.
Right. Thank you very much, Nuhu. Thank you to all the participants. So I'm Dr. Janet Karimi from Kenya. I'm heading the Division of Newborn and Child Health. And I'll just give you a brief of what we've been doing in Kenya with regard to quality of care. I'll start with the background of where we are in terms of performance in our under 5 and newborn indicators. Next slide. So Kenya, we've made remarkable progress in reducing our under 5 mortality. You can see from a peak of 115 per 1,000 live births in 2003. Right now we are at 41 per 1,000 live births. But we've stagnated more or less in terms of reducing the neonatal mortality. We are at 21 neonatal deaths per 1,000 live births, and the neonatal deaths are actually forming 51% of the under 5 mortalities in Kenya. So our efforts in the next planning period and currently basically are targeted towards seeing how we can reduce the neonatal mortality and bring down the overall under 5 mortality. Next slide. So our programming in Kenya for the newborn and child health program, we do this through the Division of Newborn and Child Health, which has 6 sections. So we have a section dealing with primarily newborn care in terms of the essential guidelines for newborn care, KMC, chlorhexidine use for the cord care. Then we have another section which deals with facility-based management of those children who are above 28 days, and this ITAD falls under this, the integrated management of childhood illnesses, development of guidelines like the basic pediatric protocols, which is for 0 to 5 years. We have the community-based services arm, which looks into the mother-child booklet. I think most countries use this booklet as a form of follow-up for the pregnant mother, the child up to 5 years for vaccination, and even the wellness clinics. And it has a lot of health information messaging so that we deal also with the preventive and promotive healthcare. We have community maternal newborn care, which is a module delivered or taught to the community health workers, and they in turn then are able to follow up with the mothers and newborns at the community level. We have the integrated community case management of the common childhood illnesses, the pneumonia, diarrhea, malaria. So those are the community-based services and primarily delivered through the community health workers. We have the nurturing care for early childhood development, ECD, so which is really coming up right now so that we ensure every child reaches their maximum potential. And we're seeing how to integrate this into our primary care services and also the community, services and the primary health facilities. We have monitoring and evaluation of all the programs, and we are trying to see how to streamline services for the 5 to 9-year-olds. Next slide. So specifically on the progress made in terms of our pediatric quality of care measurement, and in this we started with the thinking of development of the standards for the small and sick newborn, and then also now for the pediatric, but we put them together so that we have standards. In our standard, we cater both for the small and sick newborn and also for the well child. So Kenya joined the QC network in 2018. In 2019, we had the country orientation on WHO quality of care standards. And in 2021, we had the involvement of the quality team and standards team to adapt the maternal newborn quality of care standards, and also now have that incorporated into the measurement arm where we have the KQMH, that is the Kenya Quality Model for Health. We have the EKQMH, which took some of those standards for measurement. So working with them to see how to measure that. In 2022, we had the launch of the maternal newborn quality of care standards, which have 11 standards. So we adapted 3 more, because the one for evidence-based medicine, there was one standard dealing with the woman of reproductive age and another one dealing with the women who are in labor and delivery. Then they added a standard on safe surgery and anesthesia and another one for community. So following this is when we've been adapting the standards for the sick and small newborn and putting it together with the well child and calling it the pediatric quality of care standards. So that process has been ongoing from 2022. And right now in 2023, we have a draft pediatric quality care of standards document. We have an indicator catalog, and we have the core indicator catalog, which I think has 45 indicators currently. We had the MAP WHO team from Geneva and regionally come to map the 25 global pediatric and adolescent quality of care indicators. So what is then planned next is the harmonization of those mapped indicators for pediatric and adolescent care with what we have as our draft pediatric quality of care standards. When we do that harmonization, we plan now for the launch and implementation of this standard, hopefully by November. So this is a summary of maybe the slides which will follow. So I might not go into details into the next slides. Next. So as I've mentioned in the last slide, we have the draft pediatric quality of care standards developed, which includes the standards for the small and sick newborn. Our indicator catalog has 65 indicators, but out of this, we want to develop a smaller subset, currently at 45, and maybe they can be reduced further, so that we can look for a mechanism to monitor this routinely and use this to select areas where we can go in and give support, supervision, and mentorship to the county teams and facility teams to implement these QOC standards. So we developed a health facility assessment tool also, which was piloted in 10 counties. The feedback was that the tool was easy to apply and captures the key issues around quality, but we needed to customize the list of equipment. When we ask, do you have the standard equipment for newborn care and resuscitation? We need to have a standard list, which also is matching with what is in our Kenya Essential Medical List or equipment lists. And then we also need to standardize the scoring format in all sections. So we have one county where this tool was piloted, which used this tool in their facilities. And based on those findings, the success is that they developed an action plan for improvement based on the assessment that was done. It's something then when we actually do launch, we can scale up to all the other counties. Next slide. So as mentioned, we had the WHO team, which came to give support to map the 25 core pediatric and young adolescent quality of care standards as part of the support to countries to support the uptake of these global indicators into the national health information system. And out of the 25 indicators, Kenya was already collecting these 9 indicators. So when we do harmonize these global indicators into the pediatric quality of care indicators, we'll have one comprehensive set of indicators. And then from that, we see which of these then can we routinely collect from our KHIS system and which ones then do we need surveys or other mechanisms of data collection and follow-up for. Next. So currently in our EKQMH system or KHIS system, we have 11 indicators which were part of the maternal newborn quality of care standards being collected. But you can just see as an example, for example, this is for a specific health center in one of the counties. So like the third one, 9.3, says the facility shall be adequately prepared for resuscitation of newborn babies within 1 minute of birth. So there are key aspects that go into that, and then the scoring is done, then you will find that the overall score, the highest score is 3. So where the best performance scores are 3 and the poorest performance scores are 1, which in this case is this, the next example, the facility shall have a mechanism for detecting and referral of babies with danger signs or critically ill babies. So these are some of the indicators that are there currently, but we are looking to expand that. Next. So what are some of the challenges that have been faced or that we anticipate? The first would be the resources to disseminate and implement the pediatric quality of care standards widely in all counties, because this would involve, after the dissemination, the training of trainers on the pediatric quality of care standards and the quality improvement approach, which shall be used to pick out the key issues and maybe do quality improvement projects so that we can score well on the quality of care standards. Then the second one is the institutionalizing of the standards such that beyond this improvement project, let's say to increase proportion of low birth weights who receive adequate thermal care or those who receive adequate feeding care. Beyond that project, we've met our targets, maybe wanted it to be at 90%. When we achieve that, how do we sustain those gains, even as we move to another standard to improve? Then we need to look at support for routine monitoring of the QOC indicators in our routine systems. And quality of care goes beyond just these standards. And even within the standards, we do talk about sufficient skilled HRH. We do talk about referrals, commodities, and equipment. So even if we build the capacity of, say, the healthcare workers, we need to look at all these other aspects that come into play in terms of quality of care. So we are aware, cognizant of the fact that just implementing or supporting the counties to implement these standards will not be the magic bullet. We still need to strengthen these other areas. And then we've added the 9th standard on community, but we do not have the global indicators. So maybe we can also support the global in terms of, coming up with these global indicators for that. So next slide. So the opportunities in Kenya, we are fronting the use of the primary care networks, which is the hub and spoke model, where the higher level facilities support the lower level facilities to improve the services that are being provided. So in terms of the pediatric quality of care standards, where after we have the TOTs trained, they will then train and mentor the level 4 in facilities, who in turn train and mentor the level 2 and 3 facility healthcare workers in implementation of these standards. We have different partners, but I think we are all on the same page on the place that quality of care is holding to take us to the next level in terms of reduction of newborn and child mortality. So as long as partners collaborate and support the government in working in the different counties or regions, then it's a good opportunity to do the scale up. Then other opportunities, of course, expansion of the eKFMH platform or in our health information system to collect more indicators and monitor. We've also put quality of care as one of the key activities in our EPMM and in-app country plans. So I believe by doing that, it will also attract more funding from other partners globally and also locally. And then we work together with the maternal health and QI teams to implement maternal and pediatric quality care of standards, because we have to start from the mother for the reduction of neonatal deaths to actually happen. We've also have opportunity in terms of advocacy at the national and county levels to strengthen the health systems to support quality service delivery. Next, I think to my last slide. So after we do the analysis of the mapping that was done for the 25 WHO pediatric and adolescent indicators by WHO, we shall then do a harmonization to incorporate these findings into our pediatric quality of care core indicators and have then the validation and launch of our pediatric quality of care indicators. The catalog, the catalog has all the indicators. Then we have the core indicators catalog, and then we have the assessment tool. Then see how to incorporate this into our routine data monitoring systems, and then disseminate these PQC standards and training of TOTs from next year, and see how to follow up on the implementation through support, supervision, and mentorship of that. So that is where we are at now. We are almost at the final stage of the process, and the major implementation then will follow after that. Thank you.
Thank you very much, Dr. Janet. So, Dr. Jessica, I'll hand over to you.
Thank you very much, and thank you very much, Janet, for setting the pace. I'm called Dr. Jessica Nsungwa-Sabiti from the Ministry of Health, and I'm in charge of reproductive health and child health. And I'll be briefly sharing our experience, slightly different from Kenya, but also it reflects how we've been able to build on what has been existing. Next slide. Yeah, I think this is one of the drivers that we are not attaining our targets. So I'll not go through that one, I think, because it's a common problem across Africa. Next slide. And briefly, very briefly about the timelines we used to introduce the pediatric quality of care. Uganda is one of the pathfinder countries, so we have already developed the MNH standards. Actually, in Uganda, even before the launch of the WHO standards, we had started working on some work on newborn health. So when the launch of the standards came, we were able to finalize. And then more recently, we have moved into the quality of care component. Next slide. I think I want to spend a bit of time on this slide because our work has been happening in 3 processes. We started off with the planning phase, where we critically discussed the entry points for the pediatric quality of care indicators or quality of care process. And then we decided on the objectives for improving quality of care. Again, as much as possible, we aligned this to the learning network objectives. And then we agreed on the steps to take to achieve these objectives, assuming that already some other work has already been going on. And then we also had a lot of consensus and discussions on the measures to achieve for quality of care. We also had another parallel set of work where we looked at the WHO set of standards for pediatric care. And we went through a process of trying to adapt some of these indicators, measuring on the core pediatric indicators or most essential indicators. We also developed a quality of care assessment tool based on the standards. And unlike Kenya, we've been building on the same tool. We had a maternal newborn indicator standards assessment tool. We added on the maternal component, and now we are building on the same quality of care for pediatric standards. And the reason for this was that we did agree from the beginning that we were going to have a fully functional quality of care process for each health facility. So rather than having parallel tools, it was agreed that we build on the same tool. And this tool comes in several components. We have a component which looks at the management systems, which includes the information systems. We have a component on the medicines and the infrastructure. And then we have the clinical component on standards on clinical component. And then we have a health promotion, which also has a community component. And then we have an additional component on infection control, because it was felt that this was very significant. So in addition to the standards, as part of the quality control activities, we've been able to do intermittent periodic assessments, and the emphasis here has been to build capacity at the point of collection at the health facility, so they have tools which are easy to use and they're able to do their regular self-assessment in addition to what we do when we come in externally, and they're able to take action when performance doesn't match the standards. We've also been working on another component, and this one actually we've been working with the quality assurance department to set into place capacity for doing quality improvement processes, where people have been trained to set aims, to diagnose the problem, to test their remedies, and apply the successful or best practices, and continue sustaining the process. So there's been an approach across the board where quality assurance is taking lead in setting and building this capacity for doing QI processes using the PDSA approach. So I wanted to spell out this, that for us in Uganda, we are actually building on what we have already started to be able to achieve a more comprehensive tool to fully assess the functionality of the facilities. Next slide. So these are the packages. This is the main aim of strengthening our healthcare system. We have on one side a basic package for the primary care facilities, and then we have a package which is dealing with more severe, complicated complications at the secondary and tertiary level. And then in between there, we also have a CRVS process where we have the death surveillance, the birth registration, which is part of the whole package. And then we have three main areas of packages we are working on. At the primary healthcare level, we're using the basic NCI as an entry point, which basically looks at common childhood illnesses, but also includes nutrition and immunization. And then at the higher level, we have the ETAT Plus, or the emergency referral care package, which is being used as a tool and an entry point for us to do QOC. But we also have other specialized care levels where we do, for example, cardiology, nutrition units, and even sickle cell. So those are the other additional components for advanced care, which we are going to build on much later. And in addition to these three main entry points, we also have the prevention, protect, and treat component, which came in as a part of the advocacy for diarrhea and pneumonia management. And the main emphasis here was to see how we can mainstream and integrate the zinc and ORS co-pack, but also look at the oxygenation issues for the children. And at the community level, we have the ICCM package. This one has been expanded to include screening for HIV, tuberculosis, and malnutrition. And this is done by our community health workers. And then we have a population-wide arm where we do outreaches, child health days. So this is basically done periodically by the health facility when they reach out in the community. And then we also have another very interesting component, which is called the post-discharge follow-up and care. We are working with a team which has developed a smart discharge tool, which is able to predict which babies are admitted who are likely to die in the community. We've been able to see from this work that more children die post-discharge. So a tool has been developed which can predict those babies who can actually die post-discharge. And we're using the PDSA cycle to follow up these children to improve the discharge processes, but also make sure that we align this with the main referral process. And this has been very instrumental. In 1 year alone and in 3 sites, we're able to reduce mortality by 30%. So we're now discussing how we can actually expand this in the refugee settings, in the urban areas. And I'm actually now up here in the district where we're discussing on how to expand this smart discharge component. So it's one of the entry points also we're using to improve quality of care in the country. Next slide. So as I said, our main entry points have been the pediatric death audit tool, which we have done with support from our partners, UNICEF, especially and WHO, but also the ETAT and the IMNCI and the smart discharge. And then also previously some work has been done where we have used nutrition and the MyCan guidelines as an entry point to quality of care. And then of course, we're also doing pneumonia with a focus on oxygen. And this has become very prominent post-COVID pandemic. So these have been our main entry points for doing quality of care. But the idea here is to build on everything and eventually have a more comprehensive process. We've been able to do the adaptation of the WHO pediatric audit tools, including the introduction of the ICD 11, which is being rolled out gradually in phases. And also we are working, one of the things we're also doing, we are targeting the same districts where we have been doing MNH learning. So we are building on the same site. However, we have also taken on some new sites based on the interest of the partners for the pediatric component. And the indicators we have developed we have now developed a proposal which has been adopted for the HMIS tool, but also we are having a discussion with our World Bank and GFF team to see how we can add 3 more indicators from the pediatric core indicators as part of the results-based financing. And this process is ongoing. Next slide. So as I said, we have been working with the GFF and with funding from the World Bank to promote this pediatric component. And we've been able to pilot and expand to 18 health facilities in the 6 learning districts, the global learning districts. So we are building on gradually more health facilities in the 6 districts. And this has been able to provide us experience on how to build on the pediatric component. We are learning lessons from the maternal newborn component, and we are hoping that this will actually strengthen even the overall process. We still have a patch implementation of the pediatric component, but we are hoping with the foundation which has been set by the NMH team, we'll be able to really move faster. We've also developed a system for documentation of the outcome of the pediatric quality of care, commonly known as the ComCare PID QOC indicator system for implementing the QI aspect for pediatrics. And this has been used for routine discussions, as I will explain in the next slides. So QI change packages have been emerging and mostly on the IMNCI, and we've been able to facilitate health workers to exchange knowledge through collaboratives. Districts have moved from different districts, but also they have a WhatsApp group which they use. And these have been able to provide us appropriate information on the care of children, mostly with cough or difficult breathing, and also on correctly assessing and treating children with fever. These two have been very prominent because increasingly we are having fewer children in the area. So these have been our main areas. And every week we have CMEs and drills, where we discuss some of the challenges, some of the experiences, some of the way people have gone around the issues. And this is commonly read by the lower level health workers. And we have developed algorithms which display the solutions, how the solutions are arrived at, both clinical and administrative solutions. And we're also using this actually to track the medicine stock out, because this has been also a very big problem. And we use it also for discussion in the change packages And this has also helped us to realign and reorganize the health facilities, especially in terms of reorganizing the staff responsibilities. So every week we have a meeting and some of these things emerge and we find solutions, but also we discuss the levels of people to solve the solutions. Some of the solutions are addressed at the national level, some of them at the district level, and most of them we encourage them to be discussed and solved at the point of collection at the health facilities through their team processes, but also trying to see how they can actually be innovative. Next slide. Next slide. So I wanted to share this one. I would have loved to share some pediatric data to show how we are beginning to realize changes in mortality. This is on perinatal deaths, and you can see over the years what is happening, that we are gradually beginning to make a dentation on the number of deaths. You can see on the upper line, the blue line, we have the perinatal mortality, we have the stillbirth, the macerated, and then we have the fresh stillbirth, and then the early neonatal mortality. The mortality has reduced by almost 36.4%, and this is based on institutional data. But the greatest reduction has been registered among the macerated and the fresh stillbirths. There's been a lot of emphasis on the stillbirths. However, we have not seen as an equivalent reduction on the early neonatal deaths, and we're trying to work out some of the issues around this particular age group. Next slide. I wanted to share this because this is how we are continuously building on the other processes. As I said earlier on, we did prioritize the entry processes, and we have introduced them and we continue appraising them for the pediatric component. And we are hoping that over time, we shall continue adding on the other components. So we started small, even with the pediatric component. We began small with some more easy, more readily available areas where we can work with other partners. And that's IMCI and ETAC, as I said, and also nutrition. And we are hoping that gradually we'll be able to add on other components for that. So we have a cyclic processes which we're using. Next slide. So some of the lessons we have learned from this process, we have learned that consensus building takes time, and we need to prioritize at the initial process for the implementation. This is because I think if you look at the pediatric component, unlike the other component, there are so many players, and we need to go where there was readiness and where there was already interest for us to start or build on. The other thing we have learned is that we need to have a strong coordination structure at the national level. And this was done deliberately, that we start with a lot of emphasis and manage the process at the national level. And more recently, we're now phasing it off to the regional level so that we can actually delegate more responsibilities. And this has been mostly done by both the child health team and the quality assurance department, working through our Ministry of Health technical working group to make sure that this can be sustained over time. There is also a very important need to define the entry platform for introducing the pediatric quality of care, because if this is not clearly thought of, I think then you're likely to go into a project kind of mode. It's very important to think through where you start and then agree how you're going to add on the other platforms, because then this allays people's anxiety that actually this is not just a piecemeal approach. Of course, it's important to also learn that there's synergy in building on the existing MNH quality of care, because one, they've been at it a bit longer, but also the country has been able to build a great momentum on MNH, and we felt that it was easier for us to build on than to preach a more parallel process. But this also takes a lot of time to be able to agree. Luckily enough for us, both maternal and newborn child health are in one department, and I think that was an advantage. I believe that in other countries to take more processes, but this has been also a very big, strong aspect in our country. We need to institutionalize the data collection for the pediatric in the existing HMIs. We know the challenges of HMIs, especially concerning the process indicators, but we are also trying to get proxy indicators for measurements, which are able to flag up teams to go back and do deeper examination of where the gaps are. So we've not been able to introduce all the process indicators, but we've been able to introduce some of the proxy indicators which can flag a process for us to go and do maybe more confidential interviews or examine. However, in the RBF component, we have been able to push more of the process quality indicators, and I've been allowed to present to include 3 more indicators for pediatrics in addition to the other 11 indicators for MNH. Next slide. Yeah, I think that's all I had to present. In summary, a lot of emphasis in Uganda is to build on what we have already been doing, MNH, but also to make sure that there's a clear-cut demarcation between the issue of quality control and quality improvement, that we try to align the 2 processes so that people don't focus only on the standards, and they make sure that there's a continuous process and capacity is built by the quality assurance department. Our tool for assessment, which is a fully functional health facility assessment, has been building over the time, and I'll be glad to share with you our tool. We've been building on the standards for maternal health, for newborn health, and now for child health, including the health promotion and community component. We've not been able to add on the ECD component, but the discussions have started. We are yet, unlike Kenya, we're yet to add on the indicators for the nurturing care framework. However, some of the indicators already are implied, like the breastfeeding, the nutrition indicators are already implied, and the child survival indicators at large. So I want to stop there and really thank you for listening to me.
Thank you very much. So Annie, I'll hand over to you.
Thank you, Nuhu, and a big thank you to Dr. Karimi and Dr. Jessica for these very practical and insightful experiences that you shared. I'm really going to try to just shortly re-amplify some of the voices that we heard. So we leveraged the opportunity of the recent Quality of Care Network meeting in Ghana to have a deep dive breakout session on pediatric quality of care with about 25 people from different countries, different implementing partners, to understand what do we really need to do to ensure that on the one hand side, pediatric quality of care is part of the overarching quality of care efforts and work in countries at all levels, so at national and subnational level, but also to make sure that quality of care is really at the center of all programs that deliver child health services when it comes to planning to implementation. And I think, you know, the timing of these discussions is good. There's parallel efforts, and you heard about that a recent effort was launched called Child Survival Action, which really tries to partner with countries and think about what are some of the key priorities to move forward and reduce under 5 deaths that occur beyond the newborn period, and quality is really an important component of that. WHO AFRO recently held a meeting where we discussed IMCI in the region, and realizing that quality is also a big issue, as you all know, in the really implementation of the IMCI strategy. So what we discussed with the participants in Ghana was to really see what are some of the barriers and opportunities to advancing pediatric quality of care. Next slide, Sita. And there were really relatively few barriers, and you'll see in the next slide that all of these were mostly transformed immediately into opportunities in those discussions, which was encouraging. But the barriers really mostly are around a lack of maybe socializing and having the right champions that really advocate and find solutions for addressing quality of care for children, for child health services, both at the policy and the service delivery level, and that including also teaching facilities in the private sector. That there might be maybe issues around, you know, proper or effective coordination within the Ministries of Health, because there are different programs that need to be coming together around quality of care for child health, and Jessica just alluded to that. And then, of course, human resources is always a problem, but maybe that there needs to be a sensitization and education of the pediatric cadres to drive pediatric quality of care from the technical side and really inform the priorities and the issues that should be addressed. Data are at the center of quality, and you know, we can only improve quality when we have good data, and quality data collection remains an issue in many places. Also, both Dr. Jessica and Dr. Karimi mentioned community-based services for child health, child survival interventions, but also I see that early childhood development colleagues on this call it is important to also think of community-based interventions, acknowledging that the standards and indicators that we have right now at the global level are focusing on health facilities, but also seeing that these can be easily adapted to be inclusive of some of those community-based interventions. We need to learn. So these experiences that were shared right now, and if anyone on this call has experiences to share, please let us know. We'll find opportunities to bring these out and share with all of you. And then there are more sort of broader issues around ensuring that there's funding for quality of care considered in child health programs in the planning and budgeting, and then the broader health system issues that affect quality improvement and quality of care overall and program performance related to HR, stocks, etc. But then we went to the opportunities, and if you go to the next slide, Sita, there was really agreement that countries have worked well to establish ecosystems for quality, and that there's a lot to learn and to build on from the maternal newborn health experience. But that there might also, particularly when it comes to pediatric and child health services, experiences and ongoing work on quality improvement by other programs that all feed into what we see as IMCI in countries. So that might be the malaria program, the HIV program, or the nutrition program. It's important to ensure that child health focal points are included in the relevant discussions, both at the national and the subnational level. And you know, the issue of not starting with pilot projects, but rather targeting systems and systems changes, and implementing and establishing systems for quality improvement is something that I think the network overall decided as a priority coming out of the network meeting. As Nuhu said in the introduction, for child health and for really making progress and improving quality of those key crucial services for children, we need to look at all child health entry points, and that is maybe, you know, expanding from what the focus was of the maternal newborn work in the beginning of the network. And IMCI delivered at the primary healthcare level, but also the community level, could really serve as a good starting point, as Jessica already shared, for pediatric quality of care, given that that is the level and those are the services that the majority of children access when they fall ill. And of course, in the facilities, you know, it is an easier step to expand from what is already done around maternal newborn quality of care in these facilities and expand that to include all pediatric service delivery points, be it ETAD, the PICU, pediatric wards. And then when you scale up from the maternal newborn pilot sites to other facilities to do it for maternal newborn and pediatric at the same time. There is a need to build quality improvement capacity, and this has come a little bit up in the presentation from Jessica, that you really have to make sure that everyone is familiar with the terminology that we're using. What do we mean with quality improvement? How is quality the same or different to what the programs are already doing when it comes to improving monitoring, or, you know, reducing the training, but maybe moving more towards supervision? How does that relate and to the coaching efforts done as part of quality improvement, for example? And then just to make sure that those people that become coaches and mentors for quality improvement for pediatric might not be the same people that are already engaged for maternal and newborn health. So this comes again to capacity building. We've heard from Kenya, pediatric quality of care indicators exist at the global level. Some of those are already in HMIS in many countries. So there is really an opportunity to start measuring and monitoring and then building on this. And we also heard about the pediatric death audit tool. Many countries are moving with those. So that's a very practical entry point for initiating quality improvement as part of facility processes. So those are some of the issues that came out of the network meeting. I think they're very closely linked to what we heard from our other two colleagues. And with that, I pass it back to Nuhu.
Thank you very much, Anne. And I think we come to the stage. I mean, we're short of time, but I think we can take a few questions. I think maybe the first questions, which I was either I'll direct to Dr. Janet or Dr. Jessica, just either of you can answer it. I think it would be good, useful to learn from you compared to maybe maternal and newborn health. I think child health, the interventions from child health also involves a lot of other programs, for example, malaria, nutrition, HIV. So what mechanisms are being used in place right now at the country level to engage with these other programs, including the fact that some of them also have their own quality improvement structures and platforms. How are you integrating all of this together in your implementation?
Okay, maybe I can go first. Actually, if you look at the history of quality of care in Uganda, the HIV people have already been doing quality of care. They have a HIP-QAL project. And then more recently, malaria has embarked on auditing deaths for malaria. And previously they were running parallel, but recently when we introduced the pediatric component and brought them on board, they were able to realize that some of the components which are very important, especially the systems component, we are missing in their approach. So they've been able to come on board gradually. And one of the biggest point of discussion has been which indicators to include, because they are very much interested in having a specific indicator. So one of the things we are doing is that we have an indicator, but then we have the numerator can be broken down in several units where they're able to track some of their indicators. So it's true, malaria is very much interested, HIV is very much interested, and nutrition also has a history of doing quality of care. So the idea that we have a more comprehensive approach and we have all these standards from the PQOC, WHO guidelines has helped them to realize that they need to come in and work together. Thank you.
Dr. Janet, do you want to add anything or do you want another question? You want us to?
I'll just speak briefly to it. I'll say the collaboration is key. And even as we've been developing our pediatric quality of care indicators, we've had representatives from each one of those divisions or areas. And especially key for us is the maternal health, so that whatever we are doing, we are working together with them. Even in planning and in applications, even for, let's say, funding. Right now, we are doing it together under the Global Fund, and we're seated together with the teams from HIV, TB, malaria, and nutrition. So all these stakeholders we work together with, and we have the umbrella department of standards and quality assurance, which also are key in bringing all the teams together.
Thank you. Dr. Janet, there were lots of questions around early child development. I think as countries begin to think about how the child are well then. So how are you already thinking about ECD, integrating ECD, whether it's in community or facility-based service and looking at quality of care, quality care?
Right. So there was a question, I think, also on if we are including ECD in the quality of care indicators. We already have that for Kenya. So we have like the proportion of facilities which enable access to play and education materials to the children during hospitalization. We have another one measuring proportion of facilities which give routine growth monitoring and assessment for delayed milestones as documented in the MCH handbook. So we've already incorporated those. Number two, the question on how do we integrate ECD into the community and into the facility. We have partners who've been working in specific counties, and we want to leverage on their work to see how we can develop guidelines for institutionalization of now ECD in the community and at facility level. Number two, we have draft training material for community health volunteers on ECD so that they can take this to the community level. And we are in the process of seeing how we can develop in-service and pre-service training material for healthcare workers so that they can take up this ECD process in our primary care facilities. Thank you.
Thank you very much. I think similar question, but to Dr. Jessica, I think lots of interest around community level, improving care at the community level. And I think the question is at community level where you're implementing ICCM and other child health interventions, what processes are you using to develop tools that can measure quality at that level? I think that's something that people are really interested in.
In Uganda, one of the course advantages we have is that we had the ICCM program has been running for some time, but also we have an approach called catchment area planning and action. In some countries are doing this also. So through that process, we were able to introduce some indicators to measure quality in that whole process. And those indicators inform the health facility on how they can actually respond in terms of supervising the community health workers. But also gradually we are training the community health workers to appreciate the importance of quality. So the first step was to use this information at the health facility. So they collate all this information and they use it to discuss with the community health worker. in a catchment area. It has helped them to set the denominators, because that's always a problem. So they do a denominator, they agree on the denominator based on the care-seeking behavior, which patients are coming from where. It's not very obvious to know who's in your catchment, because sometimes people go across even when they're supposed to be in your catchment. So that tool has helped us to build a dialogue and be able to establish the community indicators. Right now, our focus with the IC scheme is to look at the quality of care in terms of prescription of medication, but also storage of medicine is another area we are looking at, but also the referral component is another area we're looking at. So we're gradually now also going to working with the community health workers so they can actually appreciate that it's not only treatment, but also they must be thinking about how they improve quality, how they discuss when they come to the meetings, how they have been able to come up with some solutions as they care for the children.
Thank you very much. And just a final question to you, because unfortunately we're running out of time, but I think having listened to the first two presentations from Kenya and Uganda, reflecting also on what you had in Ghana, what do you think are some of these, do you think are some of the gaps in terms of the tool guidances and supports that we should be thinking about at all levels with partners, with countries in terms of to advance pediatric quality of care?
Yeah, thanks, Nuhu. I think one thing is to have just some practical, simple guidance, if I may call it that aligns the terminology for what do we mean with pediatric quality of care and brings everyone on the same page and maybe, you know, frames it in a way that it really relates to all the different programs, as we said, and as you both, Dr. Karini and Jessica said, you know, brings together the different programs that deliver high impact interventions for children, and what are the key approaches and very practical steps to advance that agenda, building on those country learnings. I think that's the key thing. The other one I do think is the measurement, and how does that relate to understanding program performances. So, you know, these assessment tools that we heard exist both in Kenya and in Uganda. How can we share those? How can we, you know, make those generically available for other countries to really start thinking about what are the issues and what are then our priorities for quality improvement? What are the data that we're already collecting, or what are the data that we do need to collect on a maybe once in a while basis, and as well as a routine basis through HMIS to advance pediatric quality of care. But I think, to me, and I wonder if that resonates with Jessica and Jeanette, it's more about what are the practical steps now to move from a global document that outlines standards to how do you do that in your context?
That's a very interesting one, because when we first wrote these standards, there were so many, the indicators were so many. And I think it took us some time to really work out how we were going to adapt them. But luckily enough, in Uganda, we had previously a Yellow Star program, which had structured these indicators, these standards. So it was very easy. And as I said, it was in 6 domains. We have a management systems, which looks at the registers and so on. We have the infrastructure element, which looks at the equipment. And then we have the clinical component where you're monitoring and looking at the protocols. Are people trained to use them? Are they available? Is there an emergency? Is there a triage? And then we have the health promotion and of course the infection control. So we actually adapted that same approach. And then we looked through these global indicators, and they helped us to define the statements for each domain. So we clustered these indicators to come up with a domain, and the individual indicators were able to define the domain or the statement. And that way we're able to make it very practical. Actually, we've developed a document, an assessment tool, which is called a fully functional health first assessment tool in triplicate. So when we do the assessment, we leave a copy with the district, and we leave a copy with the facility, and we go with a copy. And the facility continues to use this tool because, one, they are able to understand what the standard is based on the domain, because sometimes they don't know the ingredients, but also they are able to use it to identify their aims for change, the change packages, and discuss them. They've also been able to discover there are some guidelines they didn't even know that existed. So it's both a reference tool, it's also building their knowledge, but also standardizing the approach, and it has simplified their approach to doing the QOC. The many indicators in the 3 manuals were very difficult for us to practically put on the ground. We were able to monitor them through the learning network, but when you translate them downwards, then the health facilities have a lot of information to collect. Our tool also allows them to prioritize where to start. So they can assess the whole facility, but they can decide that in this quarter, we want to measure in this area. And then once they improve some of those standards, they keep adding on. So they have an additive process which is going on. We are hoping to evaluate how that works before we expand the work in the learning network, the learning districts, because we really want to have a feeling, and we are hoping that we can commission somebody just to come and understand the feasibility, the acceptability, and really ability to sustain this program. Thank you very much.
Thank you very much. Dr. Janet, do you want to add anything before we have to go up to the close? I'll hand over to Anne.
Thank you. I just want to say it seems like the same experience Jessica had of where we started with a tool first, which I think would take almost 3 days in a major facility or 4 days, but with the standards and being clear on what you want to measure, we've reduced this, and it needs to be sustainable at the facility level, something that is not something we do once and achieve that target and then move on to the next thing. I think I like what Jessica had said. It needs to be additive, not something where you start with one standard and then achieve it and move to the next one. So we're hoping we can learn from each other, and especially also from MNH, so that we can scale up the pediatric quality of care standards. So thank you.
Thank you very much. So I'll hand over to you.
Okay, so thank you everyone for staying a few minutes longer. Sita, if you just skip to the next slide. Yeah, exactly. So this was the first webinar in a series. A big thank you to both Dr. Jessica and Dr. Karimi for your really insightful presentations and the discussion. We do not have the date set yet. These will be announced through the channels from the Quality of Care Network and the Child Health Task Force yet, but we have a few topic areas that we want to be addressing, probably starting in September. The big topic of measurement, and how do you select and advance with identifying indicators that are useful at different levels. Then we thought there are experiences to share by countries on pediatric death audits and how these are being implemented in health facilities, again, at different levels of care, and what is the right balance of, how do you introduce the death audits for pediatrics compared to what's being done for maternal newborn. And then I think, and you both started to allude to those, everybody is really interested in some of these very practical examples. So how do these quality improvement efforts actually look like at subnational level in health facilities? Are there experiences to share? Hearing to you and hearing the interest about the assessment tools, I wonder if that is also something to have as a topic, and just share some of these tools and the results from some of these assessments in countries. But we are curious to hear from you in the audience, what the topics are that you would like to have presented, what would help you if you are an implementer in a country, if you're in the Ministry of Health, to learn from other countries, what are other formats that you think we should explore to facilitate experience sharing across countries, across partners on pediatric quality of care. So feel free to reach out to us. With this, I thank everyone and wish you a good rest of the day. Thank you very much.